For those of you who don't know me, my name is Tiang Chang. I am the new director of the Wasteman Center. I started on July 1st this year, so brand new. Also, welcome for those of you who are watching this online. Good morning to you too. So this is one of the four major outreach events we have here at the center, and this is for Cerebral Palsy. And I am very excited to be here to start the day, and also to give you a quick introduction of the center. So what we do here is focused on a couple of things: the developmental disorders and degenerative disorders, and through understanding human development and understanding these disorders, we hope to improve the lives of individuals and families affected by these conditions. So what are these conditions we focus on? The two major categories. The developmental disorders basically are conditions that occur early in life, either prenatal or early postnatal. And these are conditions that would usually stay with the individual throughout their life. So although they occur earlier in life, it's really a lifelong condition that the individuals and families have to handle. And these individuals affected by the condition, they vary in degrees, but commonly they would have delays and in developmental milestones, and they would have challenges with functions of their lives. And so this actually reflects many of the needs the individuals and the families have. And what we hope to do here is through research, education, training, and services to address those needs and improve their lives. And examples of these conditions are, autism, Down syndromes, and of course, cerebral palsy. And these are conditions that happen more often. And of course, there are more rare conditions such as Fragile X and Rett syndromes and Prader-Willi syndromes, Enderman syndrome. The list goes on and on. It's very, very long. And one common feature of these conditions is intellectual disability. So the other major focus of the center is neurodegenerative diseases. And different from the developmental ones, these are the ones that occur later in life. And of course, as the developmental ones, these conditions would often affect the person's life in many different ways as well. And since, I guess, the onset of these conditions, then they will stay usually with the individual throughout their remaining life as well. So these conditions, many of the common ones people are, or is more known, include the Parkinson's and Alzheimer's and so on and so forth. And I want to mention from the research standpoint, we see commonalities even between the developmental conditions and the degenerative condition, because the underlying molecular and cellular pathways are often affected in similar fashion. So, of course, the key difference between the two is that in the degenerative conditions, you often see loss of cells and loss of tissue. But nonetheless, there are common features, and from the research perspective, what we hope is that by studying both at the same place, we could learn something in common, and when you're studying one, the knowledge you gain would shed light or help to understand the other. So that's one of the strengths of the center. We have a lot of research on these different areas that could inform each other. And so the goal, obviously, to address the needs of individuals and families through research, training, education, and services is at many levels and in different aspects. And we, of course, strive to understand the causes of these conditions. We try to study the mechanisms, understand the conditions better, and we try to develop treatment and offer services to help individuals and families. So, so this is basically the overarching goal, if you will. Through understanding the cause, studying the mechanism, developing treatment, provide service, we hope to help a lot of these people. And to better understand who we are now, you know, it's always good to look at the history of the place that is sort of defining who we are today. So the name of the center is Weisman. It bears the name of this individual, Harry Weisman. And he was a pediatrician and biochemist, and also patient and community advocate. So he mostly cared for patients with PKU, and he studied PKU through his own research, and he advocated for not only PKU individuals, but also more broadly individuals with intellectual and developmental disabilities. So from the very early on, as you can see, is an integration through his own work, integration among service, clinical service, research, and outreach to help these individuals affected by the condition. So, so his legacy obviously lives on. That's what we do today. We have all of these activities under the single roof to study not just PKU anymore, although that's still a focus, but many of these other neurological conditions as we know today. And this is the origin of the Weisman Center. It, so in the early 60s, although intellectual and developmental disability was already a big problem, there was very little research and service available for those individuals. So President John F. Kennedy commissioned a lot of these experts in the field to survey the landscape and came up with recommendations to help these individuals. And through that effort, National Institute of Child Health and Human Development was born, and the one of the charge is to fund research and service effort in the area, and so that was the what we call today intellectual and developmental disability research centers across the nation. In the beginning, there were 12 of them. Weisman Center was one of the original one, and we got the grant to build this building, and currently we have 14 of these centers across the nation. And to recognize one of the Kennedy family members, Eunice Shriver, who was instrumental in those earlier efforts, NSCHD was renamed after her as Eunice Shriver National Institute of Health and Human Development. So, so this started, the effort started in the early 60s, and the center was built and opened in 1973. So that's 2 years after Harry Weisman accidentally died on operation table during a routine surgical procedure in 1971. So the Kennedy family wanted to recognize Harry Weisman's contribution to the entire IDD field, and asked us to name the center after Harry Weisman. So that's where the center started. That's where the name came from. And today, we continue the legacy of Harry Weisman and do all of these great things to help the community. So just some basic fact about the center. It's really the largest multidisciplinary research center on this campus. And we have 62 faculty members from 28 different departments, and it's under the Office of Vice Chancellor for Research and Graduate Education. We have over 600 faculty, staff, trainees coming to work here in this building every day, and there are a lot of effort, research and service effort, supported by federal and private dollars. And the clinics, specialty clinics we have here, sees thousands of unique patients every single year. So we have a lot of activities, and we have very far reach into the community. So like I mentioned, we try to accomplish our goals through many different activities, and the major focus is on research, training, education, clinical service, and outreach. And to give you a few examples, this is the type of research we have in this building. From the molecules in the test tube to the cells sitting in the Petri dish to brain imaging studies and neurobehavioral studies on human subject. So it's very wide-ranging across, cut across multiple domains, and we even have ability to produce GMP grade biologicals and cellular therapies for clinical trials in the center. So the research activity is really multidisciplinary. And for training and outreach, this is also a major focus of the center. And we have, in addition to many different training grants, as well as individual training grants, we have this LAN program. This is leadership and education training in neurodevelopmental disorders, specifically focusing on that. And what we have here is Ann Harris, who is the director of the LAN program. And here we're training the next generation researchers and service providers to carry out all these important service and outreach activities in the community as well as research. So we have a Weisman Early Childhood program, and this is a program that's modified from Harry Weisman's original vision. So he had the original plan for a school for children affected by intellectual and developmental disabilities. It opened shortly for a while, a year or two, and it was closed because it was exclusively for individuals affected by IDDs. And due to legislation changes, you cannot have segregation anymore. So those kids need to be embedded in the normal setting. It then continued as an early childhood program with immersion. Essentially, 1/3 of the slots in that program is reserved for children with special needs. And they would receive occupational therapy service embedded in the program, and it's really a national leader in the inclusive model for early childhood education. And you can read the numbers on the slide, and over the years, this is really has been a great place for children with special need. And as I know, many of those children actually got their first diagnosis in the school, not in the clinic. This tells you how high the quality the service we have in the preschool. So, of course, we have many specialty clinics geared toward IDDs, and here are some of the examples. The Autism and Developmental Disability Clinic is right on top, and we have a Cerebral Palsy program as well. As you can see, we see over 8,000 patient visits, a lot of volume here. And specifically for some of these conditions, we even have recently developed treatment programs inside our building. So this is an example of the autism treatment programs. We're doing evidence-based behavior intervention in this program. That's actually schemes developed based on over 15 years of NIH-funded basic research in this building from research labs in this building based on the knowledge gained in those studies, and we come up with evidence-based behavior intervention schemes that now we're applying in this program. So this is, of course, a great resource for the community. So this, throughout the years, there are many other noteworthy outreach activities carried out by the center, and this is one of the recent success, although it started decades ago by Harry Stevens. He's actually the first administrator of the center, if you will count him often as the first director of the Weizmann Center. He started the collections of art pieces created by individuals with IDD, and we just had a book earlier this year and an exhibit in the Chazen Museum to show many of these remarkable art pieces created by IDD individuals and just demonstrate their ability. Don't know, I had the opportunity to go and visit and look at some of these pieces, and it's really quite impressive. So some of the better known activities include the Children's Theater here every winter. It's a very popular event attended by many children from the community. And this is another type of outreach activity we have, grandparents network. Basically, this is to provide support to the grandparents of those families affected by these neurological conditions we care and study. And basically, this is a monthly coffee event for the parents to get together, very low stress, low key, for them to share their stories, to learn some knowledges about these conditions. So as you can see, we're trying to reach our goal through many of the research, training, education, clinical service, and outreach activities here at the center. And we're hoping, I am hoping, that we could do more for the community through the collaboration among these different components at the center. So this is, of course, a main outreach activity, and we do this day with the expert series every year, and these are the 4 topics we cover, and I know today it's for cerebral palsy. And so that's a quick overview of the center, and of course I'll be happy to answer any questions if there is any. If not, thank you very much for coming, and I hope you have a great day learning some pertinent knowledges and some new development relevant to cerebral palsy this morning. Thank you. So I have a couple of announcements. One is that the restrooms are just around the corner. You walk out of this door, you walk toward the stairs, turn left. There are 4 restrooms right there. And another announcement I want to make is that there are these little cards outside on the table. They have different colors, but they mean the same. If you have a question for the panel, at the panel discussion session, please take one of these and write down your questions and give them to Teresa or any one of those communication group people so that they can give these to the panelists. All right, thank you so much, and let's welcome the next speaker for the next activity. Oh, Teresa's here.
So for all of our speakers today, you can look in your program. There's bios that talk a little bit about the 3 speakers that are joining us today, as well as the moderator for our panel. So let's welcome Dr. Kristen Caldera.
Good morning. To all of you here and to all of you watching at home, I know I have a fair number of patients that really love to attend these from home, watching their computers. So thanks for making that available as well. So I'm Kristen Caldera. I am a rehabilitation physician. I work primarily with adults, but I kind of live in this world between adults and children. I work with adults with developmental disabilities, and something that has come up through my practice has been this idea of transition, and it's really a wave across the country right now, how to do a better job of this. And as I was looking through the program, and I had requested to be first, but I thought, oh, maybe I should have been last. But no, because this is something you need to think about from day one. This is something that is good to be prepared for. So I'm really excited to help give you a little bit of my perspective, as well as some of the patients that I work with in my clinic, things they've told me and wanted to pass on to you. And also at the end, open it up to questions. So my goals today are to discuss some of the differences between the pediatric and adult medical systems, to provide one tool for navigating the gap between the two, to discuss an adult provider's perspective on transition, and to discuss my role as a rehabilitation physician caring for adults with developmental disabilities. Really, between the adult and pediatric worlds, it's really just a different way of looking at things. We're still looking at the same patient and the same group that takes care of that patient, just from a different perspective. In both instances, it's a number, right? But some are seeing it as a 6 and some as a 9. So some of the similarities. The patient is still the center of this model. We still use a team approach. There's many people involved. There's physicians and nurses, social workers, physical, occupational, speech therapists, orthotists. Our goal is still the same: the health, function, and participation in community, with families, with friends. But there's a lot of differences too. Differences don't necessarily have to be bad, they're just different. In the pediatric care model, parents are really the ones in charge, right? The care is monitored by parents and the providers of the medical care. Parents carry the insurance. There's multiple specialists, and oftentimes these specialists are housed in the same clinic or the same room. There's multidisciplinary clinics, which make care really nice because it's one trip, right? There's frequent schedule up followed. There's frequent schedule up and frequent follow-up, either by phone call, or maybe you're seen every month or every 3 months or every 6 months. The adult world's a little different. The care is directed by the patient or by guardian. The care is more self-monitored. It's not as directed by your physician or your care providers. We're really here to facilitate and support medical decisions. The patient holds the insurance, and of course, when there's a guardian involved, this is assisted, but if there's not, then the patient is the person holding the insurance and managing those decisions. Much of the care is now with primary care. It's less in that multidisciplinary area where there's a lot of different specialists involved and there's a lot of overlap with those specialists. It really becomes very, very important to have an excellent primary care physician involved as well. There's fewer multidisciplinary clinics, if not zero, and there's much more time between follow-ups as well. So I figured I was going to get the question, why are there differences? There's a lot of different reasons. I wanted to just maybe come up with 3 or so. So completed growth by the age of 18 to 22 years old. So there's slower changes, there's fewer changes happening at the body. Meaning perhaps there needs to be fewer follow-ups. There's more people with developmental disabilities over the age of 18, right? So I was looking online at the CDC trying to come up with a really good number of people with cerebral palsy over the age of 18, and I couldn't find that. But I was able to find the number of people currently living in the United States with cerebral palsy. 764,000 was one of the numbers. And there's a finite number of resources. So there's only so many people, money, locations that are taking care of people with developmental disabilities. So transition, it's a process. It's not one day you have all of the pediatric care providers involved, and the next day you have all adult care providers involved. It doesn't happen, you turned 18, you're kicked out, or 22 and you're kicked out. It really is a process. It's something to start thinking about at the age of 12 is what the recommendation is. So it's about discovering. Learn about your providers, your current provider's approach, your pediatric provider's approach. How are they starting to think about transition as well? What are their thoughts on it? Tracking, really important. It's important to know your health information and to be an active part of that and to have that written down somewhere. Preparing is learning to be a part of those decisions and making sure you're asking questions. Planning is getting ready for your adult transition, identifying those people that maybe you could become involved with in your next step. Transfer of care is actually making that change. And see how low that is on the list? There's a lot that happens before that. And then completing the transition. Pediatric providers as well as adult providers want to know how your process was, how your experience was, and how we can make it better for people that are coming through behind you. So it's a scary thing sometimes, change, but I want to give you at least one tool for transition. And I really liked this picture because it shows kind of our old-fashioned tools, but it also shows a computer because technology can be a really cool thing. So I think I've been practicing here at UW now for 7 years, going on 8. And the number one thing I've been hearing when people come to meet me the first time is, well, you have my medical records right in front of you in the computer. Think about if I printed off your medical record, how many pages I would have to read, right? So one of the things I would encourage you to do, there's this lovely website, and I'm sure many people here have been to it. It's called gottransition.org, like got milk, right? And it is a very busy website, but there's a wonderful resource on here that has a medical summary is what they title it as. And it is a very lengthy paper, and I've been asking my patients in clinic, is this something that you think you would have found helpful? And for me, it has a lot of really great information, and you can print it right off of that website and fill in your own information. It asks things like, what is your primary diagnosis? What is your secondary diagnosis? And then it breaks it down into each body part. Do you have issues with bladder? Do you have issues with bowel? Have you had skin issues? Do you have speech issues? Do you have hearing issues? And it puts all of those things into nice boxes. It asks you to list surgeries, because when you're 18, you forget, or you don't really know when you had that surgery to your leg or to your hip. And down the road, when you're 50 and I'm seeing you, it becomes important that I know what kind of things you had as a child. There's a part for guardian information as well as equipment. It's really important to know when your last wheelchair was from, who the wheelchair was from, and also your most recent therapies. These things are really important to write down, because day-to-day life goes by really quickly, and soon enough you forgot when you last had your speech therapy, or who you saw, or where that was. So for me, this piece of information is invaluable, because it saves so much time that we can then really get into the things that need to be addressed in that clinic visit. My patients that I've been asking about said, I would love to bring this when I go to the dentist, because they're always asking me every one of these questions. And then I go to the dermatologist and they ask me all the same questions that you're asking me right now. So although this form that I'm talking about is 3 pages long with very small print, think how much time it's going to save at all those different appointments that you go to, and then you can just update it as you go. So you've changed your medical record from this to a 1-page, 3 pages, I'm sorry, medical summary. I wanted to speak a little bit specifically about my specialty. So specific to rehabilitation care, our focus really is on function. Function within the family, function in the community, function with peers, with vocational aspects. It includes all body systems. We do focus a lot on movement disorders and management of those movement disorders. We focus on a lot of different skin issues, pressure issues for people that are in wheelchairs or wear braces, musculoskeletal issues. As we all age, we have different aches and pains and different joint. That is a large focus that we have in my clinic as well. Lots of equipment issues, whether it's bracing or walkers or wheelchairs. Therapy is housed within our building as well. I work out of Middleton Clinic, and we have our pediatric therapist in the basement, a very nice basement, and the adult therapists are right above. And that is one of the things that is hard to transition from as well, coming from, you know, all these lovely therapists that are downstairs to upstairs world. And transportation becomes an issue as well. So our clinic has physicians familiar with individuals with developmental disabilities, as well as RNs and nurses, social worker, who is now in the adult world, who may not know as much about IEPs, just like I don't know as much about IEPs, but we sure do know about the local resources in Madison and the surrounding. We do have room for improvement. I'm always open to ideas and suggestions. I would love to have more health psychology services. I think this is a large area of growth and area of improvement. I would like to improve the communication between physician and patient and physician and specialists. I think that's a really hard thing to get used to when you're not in a multidisciplinary clinic and your neurosurgeon isn't right next to your physiatrist and right next to your orthopedic surgeon. And I would love to have a support group for adults with developmental diverse abilities. We thought that was a really cool name, my patients and I. So we've really been working on this. I would love to see it come to fruition. We have all kinds of support groups for adults who have strokes or traumatic brain injury or spinal cord injury, and I would love to see this happen because I think that's a unique group that we have yet to reach out to. In summary, I encourage everyone, a provider, a family member, or a patient to take an active role early in the process. Don't be an observer, be active in this process, because that's what transition is. It's not a single day, it's not a single event. One last thing that I was thinking of as I was driving in is about technology. And as I said, I'm really excited to be here and to be able to talk to people ahead of the game. And my colleagues and I have been thinking, how can we get the information out about what we're doing and how we I was kind of thinking Kay Caldera, maybe rehab doctor, hashtag before, after. I'm learning. But I think that it would be a really great way to get some information out, because then I can follow my really great colleagues that are coming up next on the program, and you guys could follow us. And I think it would be a really great way when you see great things like, oh, you can wear Converse sneakers that zip over an orthotic. Everyone should know about that, right? So that's kind of one of the things that we've been looking into as well. So I thank you for your time. I look forward to questions at the end, and appreciate any comments that you have. Thank you.
All right, hi everyone. My name's Katie Husted, and it's a pleasure to be here today. I am a speech-language pathologist and a professor and a researcher, and I wear lots of different hats around here at the Waisman Center. I'm going to talk to you today about some of the research we've been doing on communication development in children with cerebral palsy, and talk to you about the work in our lab, and then I'm also going to try to put out a plea for recruitment for new children. So, my lab here at the Waisman Center is called the Wisconsin Intelligibility Speech and Communication Lab, also known as the WISC Lab. Isn't that clever? We actually didn't have a name for about 10 years, and then a really clever graduate student came up with this, and I'm like, that's fabulous. So what we do in the lab, what our real mission is to understand communication development so that we can develop interventions and develop assessments that seek to improve quality of life and social participation for people with intellectual and developmental disabilities, particularly people with cerebral palsy. That's our area of focus. And so what we're really wanting to do is get the best interventions to people as soon as possible so that they can fully maximize quality of life and participation in life from as early as possible to the end. So, we all know about CP in this audience, but I want to point out that, you know, this is a very, very diverse population of individuals. And so if you know someone has a diagnosis of CP, you really don't know anything about them except that they have motor impairment. That's kind of the thread that goes through everything. But when we start to really pull apart the potential co-occurring deficits, you get a really complicated profile of abilities and challenges. So many people, in addition to motor disorder, have seizure disorder, they have problems potentially with hearing, they have cognitive or intellectual disabilities sometimes, perceptual problems, behavior problems, communication problems, or any combination of sort of strengths and challenges within those areas. So it's a challenging group of people to serve as a clinician, and it's challenging to study as a researcher because there's so much variability among people. We focus on communication in my lab. There's lots of great work going on about motor impairment and functional motor skills in people with CP, but there's been far less looking at communication. So we know that children with CP are at risk for significant speech, language, and communication problems. And so our challenge is to identify children as soon as possible so that we can get them to the appropriate therapies, the best therapies, to maximize participation and quality of life. We know from some population-based research over a decade ago that at least 60% of children with CP have some sort of observable communication problem that a physician is able to identify by just interacting with that person in a clinic visit. So that's not what testing results reveal, right? I mean, when we go in and actually look in detail at a person's abilities, we actually find that more people than 60% have deficits, because not all deficits are readily observable in a one-on-one interaction for 15 or 20 minutes. And so we've been really looking closely at what the profiles of challenges might be, again, so we can get to the best interventions to improve abilities. One of the things we know is that children with CP, or people with CP, about half of the population has dysarthria. So that's a tricky word. And basically what it means is that the motor impairments that we see in the body, the limbs, also are going on in the orofacial structures, okay? So if you have too much muscle tone in your arms, your legs, your trunk, we might see that in the face too. So it results in speech that sounds very slurred and often very difficult to understand. So this is a very pervasive problem in people with CP. So we're very interested in that piece of CP and figuring out which people have dysarthria at the earliest possible age so we can get them to the right interventions sooner. And these include augmentative and alternative communication interventions. So a really huge problem with studying communication and understanding communication in a person is that often we don't start to see problems with communication until about 12 months of age. They're there, but we can't observe them. And 12 months is a magical number because, anybody know why? What's magic about 12 months in babies? First words, right. So we don't know there are problems until a child starts to show us that they're not doing what they're supposed to do when they're supposed to do it. And so while we can see things in kids with CP like motor problems, they're not holding their head up, there are trunk problems, there's tone in the arms and legs. For some kids with CP, we don't see these kinds of problems until later when they're not doing what they're supposed to be doing, like producing first words. And so it can be really tricky to separate children who look typical from children who have subtle impairments. Kids who have really severe oral motor impairments are often very easy to see because they have trouble with eating. But the kids who are more subtle, we can't see until a little bit later, and that's a problem because we don't get them to therapy as soon as possible as well. So we are interested in figuring out how to differentiate these children who are borderline and maybe have very mild deficits from children who are actually typically developing. Because we know babies, children who are 1 year old, who are typically developing, have a great range of abilities. Some kids are prolific talkers, some kids are delayed. And so as kids get older, that range gets smaller and smaller, and it's much easier to separate typical from atypical development. So this is our challenge in kids with CP who have lots of other things going on. How do we figure out if communication is progressing in a way that is typical or atypical so we can get to the therapies sooner? I think one of the things that we've seen generally as a trend is that people don't start thinking too much about communication in kids with CP until they're sometimes 3 or 4, when they're really, frankly, showing delays, and that is missed opportunity early in life for really important communication interactions with caregivers, with other peers, and so it's really important that we provide the supports and the tools that are necessary right away. So my work is really focused on how do we figure out as early as possible what's going on with these children, and how do these early markers predict what we might see later, so we can get children to particularly assistive technologies, augmentative communication supports, and intensive speech and language therapy to move them forward on a better trajectory for functional communication and social participation. So we have lots of different research going on in my lab here at the Weissman Center, and it was kind of hard today to figure out what I specifically wanted to focus on, because there's lots of really exciting stuff. But we kind of have 3 strands right now that we're working on. We've been working for a number of years on developing growth curves, or understanding how speech and language develop in children who are diagnosed with CP. And identifying these early predictors of later outcomes so we can get kids to therapy right away as soon as we can see that they're not going to have a super fabulous outcome later on, so we can change that. And then we're currently trying to understand the earliest precursors to the onset of speech. So we're trying to get to kids before they're 1. And we're recruiting a whole new set of babies to start to understand, are there things that we can see very, very early in life that might direct us to interventions even sooner? And so I'll talk a little bit more about that later. And really today I'm going to focus on talking about speech intelligibility and what it is, why it's important, and what are some of the things we're finding in terms of speech and language therapy. So I'm going to talk to you about some data and show you some results that we've collected over the last 10-ish years. We have a big group of kids with CP that we've been following since 2005. And now they're teenagers. It's pretty crazy to see kids that we started seeing when they were, 4 or 3 are now 16 and 17. So, and we bring them in here to the Weissman Center, and it's a very clinical evaluation. So they come, and it's actually a couple of hours, and we spend a lot of time interacting. We see the kids about once a year, and we are measuring their speech production, we're measuring language, we're measuring cognitive skills, we're doing parent-child conversational interaction, interaction with the clinician and the child to really characterize what they're able to do for communication. And I do want to emphasize that our focus always with this population is characterizing abilities as much as disabilities. It's often very easy to see where the problems are, and it's harder to understand strengths. And I think to really do good intervention, you have to leverage strengths to target weaknesses. So we really have a positive focus on the work that we're doing. So we have about 120 different kids that we've seen, and we're actively continuing to follow about 80 of those kids, and we're now recruiting some new babies as well, who are younger than anybody we've ever seen before. Some kids have come 20 times over the years, and we have about 1,600 data collection sessions from all of these people. So this is just an unbelievable database, wealth of knowledge that we have to analyze. It's really a lot of work to analyze all of those detailed interactions and all of the things that we are seeing in these individuals. Okay, so I'm going to talk to you today about some of our speech findings, and actually our most recent speech findings. And so this is a project where we're pulling a piece of the data that we have and looking at speech growth between 2 and 8 years of age. The youngest kids we saw were 2 in this part, and what we want to do is get to kids who are younger than 2, as I said before, so we can understand even those precursors to the data that I'm going to talk about right now. So what we're interested in here today is speech intelligibility. Speech intelligibility is the ability of a person to produce a speech signal that other people can understand. So it takes 2 people to have speech intelligibility. It takes a listener who can take that acoustic signal, that physical sound signal in the air and make sense of it, and it takes the person, a person, to produce that signal. And I want to emphasize here that we could talk about what's wrong with a signal and attribute it to the person, but it's a two-way street. So the listener has to be able to bring knowledge and skills to that signal in order to make sense of it. And listeners, it turns out, vary a lot in how good they are. And so it's not just about a disability or an ability on the speaker side, it's also about challenges on the listener side. So it matters because it's a functional measure of how understandable speech is. Okay, so I might produce speech that does not sound normal at all. It might be slurred. I might have articulation errors. I might have a low voice volume. I might speak in very short breaths or short word groups because I can't take big breaths, but I might still be very understandable. So I'm not perfect, but I'm still understandable. That's the measure we're interested in. How functional is speech, not how normal is speech, okay? So it matters because it's a measure of function, and it gives us a rough index of how well a person might be able to communicate. How understandable is your speech? And so we measure it. It can be measured in lots of different ways. The way we measure it in the lab is a pretty stringent approach where we have kids produce sentences and words for us. We tell them what to say and they repeat it back if they're able to produce speech. There's a whole subset of kids that can't talk very well, but we're talking today about the ones who are able to produce at least a word. And then we have listeners come in, regular people, students mostly, because we're on the university campus, come in and listen to that speech, and they type what they thought the kids said. And we tell them, kids are producing words, so make meaning of it. Bring your magic as a listener and type what you said, what you think the child said. And every kid gets 2 different listeners. So we know listeners learn. The more they hear, and if they hear 2 children, they'll start to learn the words that the kids are saying. So we bring thousands of listeners into the lab to hear these speech samples. And I'm going to talk to you about this intelligibility data today. So it's a combination of what the kid's able to do and what the listener brings to the task in a functional measure. Okay, so a lot going on here. I think I have a laser pointer. So the first question we asked is, does the age that a child first starts talking impact how well a child will be able to talk later? So in this project, we looked at the onset of speech. So what we see here is the black lines are kids who started talking at 24 months, okay? The red line is kids who started talking at 30 months. The green line is 36 months, and 48 months is the blue line. And what we see is that children who start talking sooner have better speech intelligibility later on. So it's a really positive sign. If you have a child with CP who's talking by 2, these kids are going to have the best outcomes, okay? If they start talking a little bit later, at say 30 months, their outcomes are quite a bit reduced, okay? 36 months, a little bit less, and so on. So we know that these are really positive signs for later outcomes, at least up to 54 months in this particular study for these kids. So that gives us important information about our therapies here. You got a kid who's talking here. You know, they're probably going to continue to make really nice changes in their speech development, but everybody was delayed at 54 months. If you think about what you know about kids that you've seen in your life, is a 4-year-old pretty much completely intelligible? Pretty much. I mean, we're actually doing a study to quantify that so we can understand what typical kids look like. Believe it or not, it's never been done, to compare our kids with CP against. But we can probably guess that a 4.5-year-old is at least 75% intelligible. And our kids with CP on the whole are not. They're like 63% intelligible. The best ones are. So they're still delayed in their speech intelligibility development, but they're making good progress. We also know that kids who start talking sooner from this study speak in longer utterances later on. So it's a really good sign if you're talking sooner. And the sooner you start talking, the better off you're going to be. Okay. Then we looked at, what if we extend this time frame out and we go out to 8 years of age in these children? This is a lot of data here, but basically these points that you see are all visits, times the kids came in, and the blue dots are the mean intelligibility across all the kids. So you can see we have a lot of variability among kids. Some kids are really low, some kids are really high in terms of their intelligibility. And these lines are standard deviations, so the average deviation around the mean. So this is interesting, right? But now we need to make some sense of it. What's it really telling us? So when we collect the lines, or when we connect the lines, these are individual children, each line is. And we ask the question, when do kids with CP cross the 50% intelligibility threshold? So when are they 50% understandable? And what we found here is that they're about 49 months on average when they cross the 50% intelligibility threshold. That's pretty late. Okay, but again, we don't know exactly how late because no one's done the normative work, which we're currently doing. So stay tuned in about a year and a half. So half of kids with CP reach this 50% threshold, reach the 50% intelligibility threshold at about 4-ish years. We asked the question too, how intelligible are kids with CP at 8 years of age? So if you look at this aspect of the figure, you can see this is the 50th percentile, that solid line right there, and about half of children have intelligibility above 73% at 8 years of age, and the other half are below. And the overall average is 63% intelligibility across all kids. So again, as a population, this group is really delayed. We can look at this and say, well, yeah, but some of these kids are looking pretty good up there, and then you got these guys down here who aren't looking so good. And yes, that's true. So our work is actually looking to separate out now in the next step, who are these groups of kids and how can we predict if you're down, you know, if you're in here, where you're gonna wind up on the other end of that. Okay, so what we see again is that there's a need for speech therapy early and continuously, because for the most part, with the exception of maybe a couple kids up here, everybody's delayed. They should be 100% intelligible by 8 years of age. Okay, so, and then we looked at what's the relationship between the age of crossing 50% intelligibility to where they get to at 8. And we found it's a very, very tight relationship. So the earlier you cross 50% intelligibility, the better your outcomes are at 8 years of age. So if you get there when you're younger, you know, like 49 months or below, you're gonna have a better outcome later on. So when you start talking sooner, it's a positive indicator, right? And if you produce intelligible speech sooner, across that 50% threshold, it's a really positive indicator for outcomes as well. So early development and the onset of talking and the quality of talking early on matters a lot for where you end up later on. Okay, now one of the things I was really interested in here was the question of when are kids growing the most? Because that seems like that's a time when we might want to really hit intervention aggressively at times when they're naturally making the most changes. So what we looked at here is this is their intelligibility, and we see that This is the age at maximum growth from all of this data. And what we see is that most of the kids, 40% of the kids, are growing the fastest at 3 years of age, okay? And if we kind of pool together these three bars where they're really growing a lot, we could extrapolate from here that it's really between 3 and 5 years of age that kids are making big, big growths in their speech intelligibility development. So it's this window right in here that kids are changing really significantly. And so that might be a time that we really want to focus on speech intervention to even push that natural growth farther, right? We looked at how many of these kids are getting speech therapy that we studied here, and it's about half of them at any given time are actually getting speech, which isn't so great because most of them are delayed pretty significantly. So, and finally, we looked at how well does intelligibility when a child is 3, so when they're in that growth window, how well does what we can measure there, right? So here's their intelligibility. How well does it predict where they are at 8 years of age? And what we found was that it's very, very highly predictable. So you can take intelligibility scores at 3 and make a very good prediction about where a kid's going to be when they're 8. So, for example, if I'm 20% intelligible at 3, I'm probably going to get up to about 62% by 8, okay? That's a big deal because that points us to intervention. If you're only 60% intelligible, you're going to have trouble probably meeting all of your communication needs, right? So we can take data from 3 years of age, understand where we're going to end up at 8, and think about changing the intervention course. It's not about speech per se, it's about communication and using other modes of communication to foster functional abilities, okay? So we like to think about communication really broadly. It's not just speech, it's lots of different modes for expression to ensure that participation. So that's a lot going on. In summary, sort of the take-home points from this are that earlier is better. We know this, right? Early signs are always really predictive, but it's never really been shown how important what we see early on is to what we are going to see later in a child with CP. And I think everyone holds out hope for speech development. And we spend a lot of time watching and waiting before providing AAC interventions, assistive technology interventions, and I think what we can see really clearly is we need to get to that sooner because what we see very early is highly predictive of where a child is going to be later on. And so we're missing critical windows of time for intervention early in life when language learning is it's so important, exposure and access and expressive modes. If you're only receiving language and you're not able to express it, you're missing such important developmental experiences. So kids who get to 50% intelligibility earlier have better outcomes when they're older. We can predict very well from what you're doing very young, what you're probably gonna look like when you're older. The window from 3 to 5 years is really, really important for speech intelligibility development. Kids with CP as a population have delayed speech intelligibility. Of course, there are some children who don't, but by and large as a population, almost all of them that we've been following do have delays, even at 8 years of age. And only about half of kids with CP reach 73% intelligibility by 8. We could argue about whether 73% is functional enough or not. I would probably argue that if you could only understand 73% of what I'm saying, you're missing kind of a lot. So we might need to add other interventions into that mix to ensure that there are modalities available for the individual to express whatever they want, whenever they want. So we also know kids are still growing through 8 years of age. Kids with CP. Typical kids are making changes in their speech development, but they're pretty intelligible by that point. I mean, they should be fully intelligible. They don't look completely adult-like in their speech motor control until they're teenagers. But our kids with CP are still, they have not flattened out on their intelligibility growth, so that's really important too. Therapy and interventions to improve speech production are still totally valid, into middle childhood. And so that's really a big deal for treatment. So we got lots and lots of stuff going on. As I said, we want to get to littler kids to know what happens before 2. And can we predict even sooner what some of these outcomes will be, or when a child might producing words, when or if a child might begin producing words. We are continuing to follow our kids through adolescence because we want to know what those trajectories of change. I showed you through 8 years, but we want to get that all the way up into the 21 years of age to get to the limit of development, so we know when intelligibility might stop developing for children, when we might have static speech motor abilities. And we're also doing work to look at eye gaze methods for our more severe populations of kids with CP. So I talked to you about kids who are talking today. There's also a big subset of people who are not able to produce speech, and we're really interested in working on methods for accessing language for those individuals as well. And we're recruiting children who are 3 years old and have severe speech impairment and motor impairment to develop new eye gaze methods for assessing language comprehension and accessing AAC systems. So flyers are out there with the research participation core, the clinical translational core, if you're interested. So here's what we need, your help for these kids. If you know them, send them to us. And stay tuned for lots more results in the coming months and years from this work. So lots of collaborators. We've had really generous funding from the National Institutes of Health for this work for many years, 15 years. And lots of people have worked on this. And of course, we could not be more grateful to the families who have been so incredibly dedicated to this work and have continued to come year after year. And so I actually feel a tremendous responsibility to get all of this information out. Responsibility to the families who have given us so much. We have to leverage what we have to make life better for kids with CP now and the next generation as well. So I thank you for your attention and your time. And if anyone has any quick questions, I think we have a couple of minutes. Yeah.
Yes, I appreciate what you said. You mentioned about the people in your studies, specifically the children, and how only half of them have received services. So what are you seeing as the main hindrance for the other half that aren't able to have that access?
Our ability to look at services is pretty challenging. So we have IEPs on the kids. And we're looking at, this was 500 and some visits. So in half of those visits, kids were getting therapy. So sometimes kids would be getting therapy, and then it would discontinue, and then it would start again in the next IEP. So it's been challenging for us to characterize the nature of therapy, the quantity of therapy, and the adherence. Were they actually getting what the IEP said they were getting, right? And so we don't have specifics about the interventions for the kids. It's tough, though. I think there are lots of misconceptions about communication and speech in kids with CP. And I think a lot of times therapists don't know what to do.
Could there be a correlation between insurance covering speech therapy in very young children and the amount of children who are getting speech therapy services under the age of 3? Because I suspect that's a big piece of it.
Yes, there could be, and we have to look more deeply at that. We just scratch the surface of those data to just address the question, as we're publishing these articles about, well, how do you know that growth is not from therapy? We don't, right? But they're getting what they get in their community, is our point. And here's what the landscape of what they're getting basically looks like. We don't know what the nature of the therapy was. It could have been reading therapy that fell under, speech and language services. So I have a researcher in my lab who's digging more deeply into that right now. She's dying to know, so look for that. Michael.
Katie, thank you for this work. It's 20 years ago we had similar work to describe motor development and cerebral palsy.
Yeah.
The language part has not been addressed 20 years.
Yeah.
For your work to come along and to provide provide this information on speech, and so I think awareness has been very poor on the speech needs of the population, and I think that's a big part of the therapy. My other question though was, can you remind me on the people in your study, how diverse were the abilities of the people? Were a lot of the children weak on one side, or
Yeah.
using wheelchairs, or what was your population?
Well, here's what's interesting. When we pulled all of the demographic information on these kids, so we have their GMFCS scores, most all of them have a spastic form of CP. A lot of the kids who were better talkers are Hemis. And their GMFCS, like 2s, 1s, a couple 3s, but these are people with better motor function overall. I was actually surprised to pull that data. I mean, I guess I shouldn't have been, but I was actually shocked at how there wasn't a good representation of GMFCS levels, at least as that sort of crudest measure of motor.
Because it really illustrates that this is not a problem only with the severely motor impaired.
Yeah, oh yeah.
It's a very large issue, and it needs to come in the forefront of what we're doing clinically.
Yeah, oh for sure, yeah. And we actually are finding that even the kids who don't have clinical communication problems, so we call them the kids without speech motor impairment, they actually have pretty delayed speech intelligibility development, so they don't look like typical kids. It's not a motor-based problem, it's probably just like a standard articulation problem that's maybe made a little worse by the motor complications in the whole body for the child. I mean, thinking about the motor system probably isn't as contained as we might think it is. And so actually, those kids do tend to catch up later on, those children who don't have frank speech motor problems, but they are delayed initially. And actually, all these kids would be good candidates for therapy, all of them, early. Yeah?
Hi, I'm here for an 8-year-old who's nonverbal, but he seems to be very intelligent. What types of technology exist for a child that age in terms of assisting with, some sort of electronic device to provide speech?
There is a wonderful array of technological tools, and I can't really hit on that whole range right now, but we have experts from the Communication Aids and Systems Clinic here who can talk to you more specifically about how you could get someone to work with you on an assessment to determine what the best tools would be for that person and to help you get set up with those tools. Because while there are lots of apps and things on the iPad, you can't just kind of go pick one out. It's not one size fits all. You really need expert guidance to help you understand the abilities of the person and how they match to the features of the technology. So it seems simple. I'll just pick something from the App Store, but it's actually much more complicated than that, and often that's a recipe for failure without that professional involvement to help match skills and needs of the person with the features of the tool. So we have got the resources for that question. So we can get that answered for you. Yeah. Any other questions? I think we have a break now, yes?
We do. We have time for about a 15-minute break. Just as a reminder, the restrooms are down the hall. And then also, if you have any questions that you'd like to ask both the clinician and the community panel, there were the little cards that Tom showed there. thank you for coming back. After the break, we're going to resume. And I just want to give you kind of a flow for the rest of our time together. So Dr. Villegas will give her presentation. That will be followed by just a brief transition into our clinician panel, and you can see the clinicians that will be available in your program. And they'll just take questions from the audience. So if you have any questions that you'd like to ask the clinicians, just feel free to do so at that time. They'll be up here for a half an hour. That'll be followed then by our community panel. I love learning about the science and the research and the advances in clinical service, but I can tell you that personally, I'm always so moved by what our community panelists have to share. So that is how we will conclude the day with the experts. And then also, I hope that you can join us if it's relevant for you to join us again for one of the other days with the experts that are coming up. But please, right now, if you'd help me welcome Dr. Villegas.
So hi everyone, thanks for having me today. I'm really excited to be here. I'm relatively new to, or back to UW, actually went to med school here, so it's nice to be back. But today I really wanted to kind of build on some of the other topics and take a little bit different direction and talk about just, I think things that we all think about as providers, parents, persons with developmental disabilities, but really trying to be intentional about how we can help kids develop independence and kind of what all of those pieces might look like. So I'm actually going to start with an audience response question. So if everyone can pull out their phones or mobile devices, if you can go to either that link, polev.com/Melissa Ville 646, or you can text 22333, or you can text 222333, so that's the number you'd enter, and you text that Melissa VILLE 646, and I think it should also work for people who are watching this from home because it isn't necessarily connected to anything here. So while people are starting to get into that, I just wanted to quickly go over goals. So I wanted to talk about some of the factors that play a role in developing independence. Really try to target and identify some ways that parents can help children develop independence, and then also explore, there are a lot of resources out there, and so explore some of the ones that I think are pretty awesome that might be useful. I want to give the caveat that there are a lot of pieces that are important in developing independence, like physical therapy, occupational therapy, speech and language pathology, equipment, all those, and this is kind of not going to necessarily talk about those pieces, but to talk about other things kind of outside of the equipment that we might talk about at a visit or at your therapy visits, to really additionally kind of add on to those other pieces. Okay, so hopefully everyone has had a chance to log in. So I wanted to just kind of frame the discussion because I think it helps as we go forward, kind of talking about what exactly do you think of when you think of independence, because I think there are a lot of potential different answers, and I think independence is broader than maybe kind of the initial black and white decision that we might think of. So yeah, you're free to text anything, it's free text, so whatever you type in will appear up here on the screen. And I just want to kind of, then everyone can kind of see what other people think about independence. I love all these answers. Awesome. So I'm going to move forward just on the kind of to make sure we have time, but these are all awesome answers, and those are a lot of the different kind of pieces that I was thinking about when I was thinking about independence as well. And then, so that's kind of what I want to talk about, is how can we work towards these goals in kids with developmental disabilities. So let's see. Hopefully I can move forward. Let's see. Oh, I think I have to click. There we go. So what is independence? I think we've all kind of started to answer that question. And I kind of made this word cloud to think about different pieces that play a role in how kids can develop independence. And there are the pieces about like learning responsibility, having the ability to make mistakes in a safe kind of manner, being able to develop peer relationships, being able to just, investigate likes and dislikes, figure out kind of what your strengths are, what your weaknesses are, and how you can leverage those strengths moving forward. And then, becoming engaged in the community, your relationships with your family. All of those pieces are how kids help develop kind of their own identity and help develop throughout childhood and into adulthood that kind of a responsibility and moving towards those next steps when they are, employed, going to school, living in the community. So I think an important piece that parents and providers do really well is advocating for children and also to support them in really having high expectations. And so kind of I think part of this is then advocating for those high expectations not only kind of within our group but also kind of in the broader community at school. And so those are some of the pieces that we're going to talk about today, is being able to advocate for inclusion and activities in the community, getting services at school that are going to help your child achieve goals at school and then in their own personal lives. And so I think that's kind of an important framework, at least to start with. So one huge piece of independence is the ability to slowly develop responsibility, and kind of whatever that might look like, being able to start knowing, eventually being able to know your care and make choices, as was mentioned in that first kind of audience response, the ability to make choices about your own life. And so I think it can start really pretty early with initially just encouraging helping around the house or at home in kind of whatever way, shape, or form that might look, and potentially, helping with chores or letting them do what they're able to when they're getting ready for their day. Sometimes speed is important, but when the time is available to, even if it takes much longer, allowing children to do every single part that they can on their own, because that really gives them the sense that they can do it, and then helps them practice those skills and helps them kind of just develop that sense of responsibility that I can do these things and that now I'm going to try and work on these next goals and next skills. And then as they get older, kind of asking them, what are they interested in, exploring those interests, exploring kind of their different strengths and abilities, and then working on having them be able to answer, if they're able, questions to the healthcare providers that they're seeing, to their therapists at school, really advocating for them to be able to have their voice and kind of their own thoughts, and then being able to express those. And then as they're going into adolescence, it becomes a lot more, even more about choice in any adolescent. And so again, giving opportunities for choice in their life. And I think a big part that I think is really challenging for any parent is allowing children to make mistakes in a safe manner, because we all want to protect kids and guide them in the decisions that they need to make. But it's a balance, and I can't say that I have, an expert opinion on what that balance should be, but it's something to think about, is in safe situations, allowing children to make a decision that maybe isn't going to turn out amazingly, but they made that decision and then they learned from it, and then next time they have the ability to go forward in a different manner. And so kind of thinking about how that might be possible. It's a challenge, I think, especially in children who have chronic medical conditions or disabilities, that because we have certain pieces that even like as a healthcare provider, for example, bracing, I'm going to say, like, I would recommend that you wear your AFOs, but, and it's a choice whether a child does that, but then as a healthcare provider or a parent, we know the consequences if they don't. So that's not necessarily something that you're going to be able to give them a full choice, potentially, but trying to find those areas that you can, or maybe negotiating, when are they going to wear the braces, and that can be their decision. Like, we want you to wear them, when would you be able to wear them? So not a decision of are they going to wear them or not, but at least kind of giving the option of like, when do you think it should happen? When would work well? As just an opportunity. So trying to find those kind of maybe creative options for choices so that they are still doing the things that we know are going to be helpful for them, but still then making them feel like they have the ability to make decisions and make choices as well. And then in addition to really being able to make choices, being able to kind of guide their lives, another huge piece of independence is identity development. And this is kind of about engagement within their own life, identifying their likes and dislikes, but also about how they interact with their peers, their goals, what they kind of want to do with their life, their eventual dreams, and all of those different pieces. I have social networks up there because I just wanted to also, and that will kind of play into the next slide, but thinking about how teenagers and adolescents kind of engage in general now is there's a lot of online social networks, and being mindful that that is a way that children are potentially going to be engaged, and that there's kind of inherent risk associated with it, but knowing that that is another potential option for people to engage in, how can we allow children to do that safely. I wanted to highlight, I did not know this coming kind of back to Madison, but there are 3 inclusive playgrounds. Well, one is nearing completion. I think they're like really getting close, it looked like. And so I think those are really great opportunities for children of all abilities to play together and to learn about each other and to meet each other and to start developing these peer relationships even from a really early age. And then I think another important piece is knowing kind of your rights and your child's rights about being able to engage in the community and at school. I was at ACPM this year, and one of the speakers who won an award was someone who advocated for their child to be able to participate in the track team at school because they weren't going to let her, and she was actually part of, the legislation that really put that into motion, and it was really inspiring to think about, these laws are in place and we can leverage them and make sure that children are included in kind of whatever activities they want to be a part of. And then there are also lots and lots of adaptive activities. This link that I'm not going to click on for sense of time, but it's a really interesting resource that basically looks at also guiding children through how to talk about their disability or how to talk about their differences, both with employers, at school, and with their friends and peers, and thinking about what they may want to talk about, what they might not want to talk about. And these are all conversations I think that are important to think about as they're going through life. How can they talk to their friends about maybe their differences? And some differences are physical and they're very apparent, and some aren't. And what do they want to talk about? Maybe they don't want to share something, and that's okay. And being able to kind of guide them through those conversations that they can have as they're making friends and getting older. And then I know Dr. Nemeth last year talked a lot about adaptive sports in the community, so I'm not going to go over that a lot, but just know that there are a lot of opportunities both for sport and non-sport. I was excited just as I was kind of looking at resources coming back to the Madison area that there's an all abilities dance class. That was something I had the opportunity to be involved in where I came from, and so I like dance, so it's really nice to see that they have the opportunity for people to get involved. There's also lots of arts opportunities, theater opportunities, so allowing children to explore what they're interested in and then try those activities and maybe like them or not like them and then kind of go from there is hugely important, and I think that's something that everyone does, but then knowing kind of what's out there, and we can help as well, help you find something that your child might be interested in. And then this, again, resource, there's for people who are maybe not in the Madison area, there's actually a list of some of the different adaptive sports throughout the state that's available as well for just potential opportunities to get involved and really be able to start developing these peer relationships. I wanted to also highlight this resource from the Cerebral Palsy Foundation. It has a lot of great information, but also has some videos from people who are living with cerebral palsy, and also people and celebrities as well. So I think it's just kind of a fun resource, and it's an app which I think is exciting, especially for potentially teens and adolescents, as a way to kind of, again, engage with other people who might kind of understand from their own perspective. So we talked a lot about kind of life outside of school and life at home, life in the community, but a big part of children's lives as they're going through childhood and adolescence is school. And so school is another place that we can use and advocate to help our children develop independence. And so some of it is being able to advocate for their IEP, but then also being able to navigate kind of figuring out if the IEP is being well served, if they're getting the resources that you think they need, if you feel like maybe a need isn't met, or maybe they're not setting goals that you think are the goals your child needs, and thinking about those pieces. And it's a hard I think it can be a hard process to navigate. With IEPs specifically, parent is kind of still the main point person. So we do have people who are available to help kind of navigate this, but I wanted to just highlight this resource. It has one of the pages that this understood.org has is kind of a list of phrases that you could potentially use to help guide IEP meetings, because I think sometimes they go really well and sometimes they can be really frustrating. And then how do you navigate that frustration while still continuing to build that relationship, knowing that you still have to work together to help your child? And so, like, one of the phrases that they have listed is, maybe this resource isn't available. What do you think we can do together to make this happen, or something like that? Like, how can we work together? So it's a really great resource, because I think, like, my initial reaction would be frustration, and then if you communicate in frustration, you're probably not going to get as far, and I think that's the case for most people. And so this kind of helps you reframe your frustrations into language that might be a little bit more productive in these meetings. Knowing, though, also that what your rights are, and being able to also kind of advocate for those. And again, there are a lot of people available to help you learn those pieces, so you don't have to feel like you have to learn them all on your own. And then knowing that you can ask for IEP evaluation as well. And then we can help potentially with, like, formalized neuropsychology testing if you just feel like maybe they aren't getting the resources that they need. That can help identify strengths and differences that maybe they need different accommodations for that aren't currently being met. And then I think another piece of school is the high school transition, which is a huge transition for any child, and thinking about how that can look and how we can use that for independence, but also how we can set that up to go really well. And part of that, I think, is knowing what's in your child's IEP, bringing a copy to the high school. Sometimes it might be very well connected in a system, but sometimes it might not be, depending, or if you've moved. And then thinking about what different accommodations they might need if they're in a much bigger building with different classes. Do they need more time to get between classes? Do they need books in different places or an iPad to help them access everything they need? So I think there's a lot of bigger questions when kids get to high school. And then there are the questions of how they can get involved at high school too, again with their peers. What activities do they want to do? What have they explored that they really liked? And so helping kids not only with the academic and the school transition, but also at the peer and social transition that high school brings, because that's really when adolescents are becoming more independent in their relationships and spending time with friends maybe more on their own. And then what happens after high school? So I know someone had mentioned employment as one of the parts of independence, and there are, fortunately, again, a lot of really great resources. I have just a few highlighted up here, but there's vocational rehab departments as well. And again, this is a little bit more focused on kind of school, employment, those pieces, but there are also a lot of resources for living in the community, for financial, kind of navigating finances and how to kind of potentially be guided in that piece of independence, and then also about medical transitions, et cetera. So this first resource has just a plethora of different websites that are attached to it. It's through George Washington University, but it has employment websites, it has some independent living resources. So I just wanted to highlight that as a great potential option. I know the Wiseman Center has lots of great resources as well, so these are kind of outside of that. In addition, youthhood.org was a website that I found that is from the University of Minnesota, and it's really interesting. It has both a parent and youth access point, and they have interactive activities that are both informational and then actually activities that kids could go through to think about medical transitions, to think about what they might want to do and how to transition from high school to employment or to school. And so I think it's a very potentially fun, interactive way that kids can learn about these choices that they're going to be making as they get older. The Midwest Inclusive Post-Secondary Alliance is another really great resource. And there's actually Beth Moss is the representative for Wisconsin for Think College in Wisconsin, and she's part of the Wiseman Center. And so this is an organization that really looks at inclusive post-secondary education, and there are actually different schools in the Midwest that have programs already in place that leverage these options and are potentially really great resources. And then there are a lot of different job websites, and so the Ability Jobs is just one of a really large potential website for searching jobs for people with disabilities and different abilities. So I wanted to highlight just some of those resources. There are a lot available. So to bring it back to our question initially, what is independence? I think everyone answered it really well in the beginning, and so I'm just going to put some of these different pieces that we talked about and that were already stated. But it's really about being able to make choices, guiding your life, potentially directing your care or doing what you can with assistance, but being able to advocate, being able to be yourself and identify goals and work towards those goals. And I think that we can, if we're intentional, really work towards helping kids achieve that. And so this, it can be applied to either my talk or the talk so far today, but to kind of also pull it back together, if everyone wants to add something that they think specific that they could maybe use that they learned today, because I think sometimes it's nice to really identify a very specific goal that you're going to implement, because otherwise I think, myself included, you know, we all have a lot of great ideas, but if we can make a specific goal, then it's more likely to happen. I like that one. All right. Excellent. Okay, so in summary, helping children develop independence is about, you know, setting high expectations, which I think we all work on, and then giving responsibility, advocating, and aiding in identity development, and then accessing providers, local resources, and national resources to help you. There's a lot out there, and we can help guide you to some of them because there is so much out there, but it's a lot available to help out. So, thank you. And I think
Great, so we'll take this moment then just to transition to our clinician panel. The clinicians want to come forward. And at this time, our community panelists will gather out in the breakout space. Yeah. Oh, that'd be great. And then Maya, did you want to find the website? You grab it.
Get your all-knowing caps on.
Yay! There's our perspective sitting here. No, that's fine.
The way it's just, I think it's one of the first. No. And to just describe this good. Okay, go for it.
I think we'll start just by having each of our clinicians introduce themselves to you.
I'm Mary Locast. I'm an occupational therapist here at the Weissman Center, and I am the therapist in the Cerebral Palsy Clinic here, as well as the Spasticity and Movement Disorders Clinic, which occurs across the street at AFCH. Hi, my name is Kayla Christensen, and I'm a speech-language pathologist. I completed my clinical training here at the Weisman Center and also worked as an SLP in several of the interdisciplinary clinics. And I'm really excited to be providing some coverage in the Cerebral Palsy Clinic later this month. And I also work at Gigi's Playhouse Down Syndrome Achievement Center, serving individuals with Down syndrome across the age span.
My name is Betsy Zahn. I'm a physical therapist at the Rehabilitation Clinic in Middleton, and at the Weisman Center, I staff the Cerebral Palsy Clinic, the Developmental Neuromotor Clinic, and Spasticity and Movement Disorders Clinic. And then I was doing a gait clinic in Middleton, but I think that has seen its rise and fall. I think it's done.
And my name is Maya Stitt. I am the Youth Health Transition Initiative Coordinator, based here at Weisman Center, but we are a statewide program, and I can provide some more information based off of the questions that we get from the audience.
And I'd also just like to have people know that Katie Husted, who presented earlier, and Kristen Caldera and Maria are all still in the room. So they might not be sitting down here, but I think they'd be happy to answer anything that we point to them. So any questions? Yes, please.
I'm a physical therapist. I work for the school district, the Madison School District. And I guess I have a question on maybe your perception in the clinic in terms of how we're doing in the schools in terms of preparing kids, the transitioning from high school into the community. But I appreciated the discussion about the IEPs and kind of looking at specific things in the class, but I'm wondering more in terms of maybe a little bigger picture in terms of the balance between, kind of academic skills and more functional skills, perhaps.
I have had some experience working in the school district myself, and I think that one of the things that at least the Madison School District is doing pretty well at is trying to help kids become more self-actualized, become more in charge of their own future to some degree. Starting in middle school, usually I would start talking to the kids about being their own self-advocate, making sure that they attend their IEP meetings that are talking for themselves. I'm not there at the school district right now, but I can assume and hope that that's still going on. That's a really big piece of the transition is as they start to, they're going on at age 14, they start that whole transition program, and to actually have that be real, where they are involved in the IEP and they are thinking about what they want to do when they grow up, and as a team, the school district is really looking at where is this child going to go and how are we going to get there.
I think one other thing that I would add is I see a variable picture. We have kids who come to clinic from all parts of the state and some other states, and so it is variable. But what I like to see, and when it is happening, I think it's great, is that families know that a transition plan is part of the IEP and that it's happening early, that the child, as they're approaching those years where they can contribute, as Betsy said, are an integral part of just doing the visioning process of, well, what do I imagine is going to happen when school is over, and dream big and think big. And then I like to see that school districts are realizing that the full team can be available to help a child move through that whole transition process. I have some school districts where it seems like a lot of services drop out in the middle school and high school levels, and they may have a special education teacher, or they may have a person who's doing transition, but they're largely not still accessing physical therapists or occupational therapists or speech and language therapists to look at how speech or AAC and technology could be used in thinking about post-high school activities. And what I love to see is when people are thinking about the goal and bringing in anyone who needs to be a part of that, rather than saying, well, we don't provide those services, so what else could we do? So starting from thinking about what does the child and the family want to be exploring, and what do we need to bring to the table to help that happen, versus the other way.
Yeah, and I think that's where sometimes the physical therapist on the team can be a help, because they can look at the access issues that the students have, as far as, if I want to have a job, how am I going to access my work environment? What kind of adaptations need to be made in that setting? And the physical therapist is the person on that team that can really address those issues.
I think too, just from sort of a general perspective, that's what makes events like these such a beautiful thing too, where people are all coming together from different disciplines, from the family perspective, a self-advocate kind of perspective, to sort of link to what do we know about best evidence, and what do we know about what's happening in our daily practice, in our communities. So I think that's what's so exciting about these events too.
Yes.
Question. So we heard a lot about speech and communication and functional communication earlier, which was just wonderful. And I have two questions. One is it ever too early to consider augmentative and assistive communication? And is it ever too late to consider that as an option for functional communication?
Oh, great questions. Thank you. So there is some really awesome research available now showing that there is no detrimental effect of introducing AAC early on. So previously there were concerns about if you were to introduce augmentative and alternative communication, things like using sign language with speech or symbols, pictures, written word strategies that we all use, that you would see a decrease in speech, or maybe it would prevent the individual from developing speech skills. But we found that there's no evidence for that concern, so we don't see a decline, and sometimes we see increases in speech too, with pairing that visual with more of the transitory sort of auditory signal. So you have something that you can continue mapping onto even when the word that you hear is gone. And for your question too about if it's ever too late, I would say no. We all are making changes always in our lives as we grow and have new experiences. And so I would definitely recommend anybody reaching out to, like, the Communication Aids and Systems Clinic here at the Weisman Center is an awesome resource to look at, like Dr. Husted was saying, that really thorough evaluation to describe the individual's strengths and areas of need and appropriately match those features for the variety of options available.
I'd like to address the whole idea of the early identification. I think looking through my lifespan as a physical therapist, which spans more than 30 years, there was a time when there was sort of this reluctance to diagnose too early, or wanting to really kind of soften the blow of the diagnosis. But now that we know what we know about the GMFCS levels and how they can be used as a guideline for what kind of things this child may need to help them in the future, that we should not be hesitant to say to a parent, I think that your child is falling into this level, and therefore here's a host of recommendations that I have. Here's some places where I think I should refer you to, and do that early so the child gets the help they need right away, and not be shy. And I myself can say that I am one of those who's been shy to break the news. But a lot of times we're on the front line, especially in early intervention, and we kind of have to take that role and to the best of our abilities and with as gently and lovingly as we can, refer that child to the places where they need to go.
How do you, or what advice do you give to parents who maybe their physician or medical people are not doing that? And the parent knows that something's wrong and sees signs of things that could be whatever, and the doctor is prolonging the diagnosis.
I could see if maybe Dr. Villegas wants to weigh in on this at all.
Do you want the mic?
I think it's really important as a parent, because if I was that provider, I think I would want that would want that feedback to say, I feel like there's something more going on, and to just keep pushing, even if that means, getting second opinions, that's okay. More brains involved is not a bad thing. At least that's my perspective. And so I think, that's easy for me to say though too, because sometimes there aren't resources available to do that. But I think then kind of continuing to ask, and maybe asking like other people, like therapists, what do you think? And then bringing that information back to the provider to say, hey, I had this conversation with the physical therapist, and this is what they're seeing, and I just feel concerned, and just continuing to express that. And I think that that's really important, and parents are huge, important advocates, and I think the information that parents give is invaluable, and so it's hard, I think, definitely to keep doing that, but I encourage you to, like, parents that are concerned, to keep pushing and keep asking and keep saying, but I think that we're missing something, or I think there's more information that maybe there is out there that I haven't gotten yet. Does that answer your question?
I think, too, one of the things that I would mention, I've worked in the multidisciplinary care for my entire career, which has been wonderful. And we see sometimes the other side of that, where families are not necessarily sure they want to engage in a lot of interventions for their child. And I just want to be clear that when we think about it as an interdisciplinary team, we talk about simply being able to share with parents things that we might know, or interventions we might be aware of, or information that they can think of, and hope to sustain just an open dialogue with them as their child grows and changes and goes through their childhood years. Obviously, once they're adult, they might move on to some other providers. But we had a family recently, and the family was just saying, we're not sure, and we were like, we're fine with that. We just want to make sure we're in communication, so that if something changes from your end, or we learn about new interventions we can share with you, we're in a place where we're communicating on a regular basis. Betsy and I and a few of us were at the national conference, or the international conference recently, and really just that sense of monitoring and sharing with families that journey, so that if there are things that we can intervene on early that may make a difference later, we're talking about it, and families are feeling like they can get information to make those informed decisions. And I always say to my families, I'm not worried about my families who are looking at information and truly making an informed decision about what's right for them. What I worry about is when I have families come and they say, nobody ever told me that. I didn't know that that was even a possibility. Oh, I wish I had heard that we could have done that several years ago, and that might have made a difference in their function or lessened a problem they're having now. Those are the ones that break my heart, because we try to get to as many people as we can. So really, both ends. If a family's feeling like they would like more information, somebody in their life being an advocate for telling them to continue to persist and reach out till they find those connections, but also reassuring families that you're with that ideally you're in a good collaborative team that's working with you to share information with you, so you can make informed decisions that are right for you.
I think that collaboration extends to community therapists that you're connecting with too. Thinking about a role within an interdisciplinary kind of clinic and making those connections with therapists or clinicians that are seeing the individual daily or weekly. I think that's so important too. And then also circling back to best practices and what we're learning from the research. So I think there's so many different layers to that collaboration.
And I'm just going to step in with just a little bit on, not from a therapist end of things, but just kind of commenting towards, oftentimes families don't know the questions to ask. What are the right questions? And a lot of the questions about, who do I refer to? Who am I supposed to ask these questions? What questions am I supposed to ask? So a lot of what my group does, I'm just going to do a little bit of self-promotion, and then I'll get back to this, is what you see behind me, the Health Transition website. So I was really excited to see our first speaker highlight the GOT Transition Group. It's a national organization that works with the transition from pediatric to adult health care. We have one here in Wisconsin, and I'm the coordinator of that program. So it's based here at the Wasteman Center, and we have a lot of really great materials that are focused on families who live in Wisconsin, as well as connections to services throughout the state. So we work with our 5 regional centers, and there's a booth right out here, or you can grab a postcard, or you can visit our website. And really the one thing that I just want to point out, if you take one thing away from this conference, research is important. If you take 2 things away from this conference, it's the readiness assessment that we have. And I would say go to this website, healthtransitionwi.org. Under the Youth and Family tab, there is a health readiness assessment, and it's questions that are geared towards transitioning aged youth, maybe as young as 12, and for the parent. And you take those questions, and they're questions that you should be asking your healthcare provider, asking your school, asking your educators, asking your physical therapists, or your OT or PT group. Go through them, and it really is a way to start that communication. And sometimes a youth might not be willing to ask those questions or admit that they don't understand everything about the world at the age of 18. I knew everything at 18. I've somehow gotten less intelligent as life has gone on. But I knew everything at 18, and I was not going to admit that I didn't know it. But this is a way to kind of say, maybe we could help you with some of those skills. And so it's really a great communication device, and it is a way to start those conversations earlier and ask the questions you don't know you should be asking.
And just to build on that a little bit, I think the transition to adulthood starts in early childhood. Okay, so kind of knowing what your having a feeling for what your dreams for your child are, what your child's dreams for their future are, and working with all the professionals in your sphere on helping to achieve those. And you can share whatever your dreams are, whether you think they're reasonable or not, because they're important. And there just might be something out there that those professionals know that might help you get there. So no question is a dumb question. No dreams are too high, but at the same time, we have to have reasonable expectations. And as a group, because we're basically like a whole village here, to try to get your child where they can be to meet their maximum potential.
Oh, come on, you guys. You gotta have questions.
Has anyone experienced that drop-off after high school where all of a sudden there was just nothing and the floor fell out from under you?
Has anyone heard it's coming? That you need to be prepared for that cliff? There's worry? Okay, I'm going to assume that there are people nodding at home, so we're going to answer that question, right?
Yeah,
okay.
Absolutely.
Do you want to start?
No, you go.
Okay. So,
I don't know why this is being so
yeah, it's not being pleasant with us. So there is that gap. This metaphorical cliff that once you hit the age of 18, services change, eligibility changes, things that were once available to you as a child or in a pediatric environment are no longer available or are soon going to be cut off. And so the idea is that we are trying to start those conversations earlier, trying to understand what parents and families need support-wise, so that when that time of transition, the actual action, the transfer of care, which I think was one of the later steps of the 6 core elements of transition, once you reach that stage, it's no longer, oh my goodness, we're suddenly transitioning, and it's more of a gradual process, which is really what we're trying to get to. Now that's all in theory, and many times families, especially families that are dealing with a more complex medical condition or disability, are managing the fires of today, right? I need to get these supports inside of the school. I need to get this type of therapy. This is what I'm being told I need to do, and you're doing everything for your child to make sure that they have those supports that they need at that very moment. you are not thinking about even next week, versus several years down the line where suddenly these things are going to change, and those are things that people want to address at that point in life. So really what we try to do is encourage those conversations to start earlier. As I said, that if you're going to take two things away from the conference, the readiness assessment is really important for kind of staging what questions you can start asking of your healthcare provider. But I would also say that there are additional resources on the website here regarding tools. We call them the 8 tools for transition. They're not evidence-based. They're not anything aside from just what we have heard from families and parents in Wisconsin about things that would be helpful to them as they talk about the transition process. And I'm going to turn it over to other people as I go over and bring up that workbook so that people can kind of see what it looks like. How about you guys take over?
So when we are following children in clinic, we may see them since they were 1 or 2, and our intention is to follow them all the way through until they transition out of our clinic into the adult healthcare model. So it is interesting when we start asking things throughout those times. What does your child do? What do they like to do? What chores are they doing at home? A lot of the things you heard, and sometimes families will look at us like, well, those are strange questions, but we're slowly adding to this thinking and this full picture of what might we be doing after high school is done or after once we're an adult in the community. So we are trying to work those things in and trying to also get better about having more formal systems to be giving families information, encouraging them to bring, when they come to clinic, questions they may be having, so we can target our resources and our planning to those, as well as building those documents with the family across time so that when they reach that point, they do feel like they have a better, if not pretty good idea of how things might go when those transitions take place. But we understand that they're scary, and nobody stuck the manual in the mailbox when any point in that child's life, and now I'm supposed to do all these things. So we appreciate that they take quite a bit of an endeavor to do, but we're here to help.
We've chatted a little bit about augmentative and alternative communication. One consideration that I would recommend too, especially if an individual is in the school setting and looking at transitioning out and they're using like a communication application on a school iPad, sort of doing some advanced planning about the fact that that iPad and access to those words and that communication system won't be transitioning with the individual, so making sure that we're connecting those families and communicators with resources where they can have their own dedicated speech generating device, so when they leave school they don't lose access to that really important resource. Yeah, and there's been each speech and language need is so individualized to each individual too. So just, I think the importance of a really comprehensive speech and language evaluation can be so helpful too, to look at different strategies that can be helpful in work settings, out in the community, like executive functioning supports, cognitive communication kind of strategies. So there's definitely so many diverse needs and strengths that a really thorough assessment can be helpful for planning.
There's also planning for physical supports that might be needed in the future, such as if the child looks like they're going to be tracking towards level 4 and 5, looking at home modifications that might need to be made in the future, helping families find resources to get funding for those kinds of things, looking at perhaps saving up for an adaptive van and starting that early so that in the future they may be able to take their child out in the community in a power chair, those kind of things.
Speaking more to the transition from like a high school setting into maybe a day program or workplace vocational program setting, what types of specific information and or resources do you give to individuals and their families, like pertaining to options that they might have? When you evaluate them, you kind of see what their skills are and you kind of see what their abilities are. How do you tailor your recommendations to people, and what direction
can definitely say that at that point, we're usually making sure they're connected to teams of people that are helping them. The clinic in and of itself is at that point more of a resource steering mechanism. We certainly are encouraging them to have a good picture of their physical needs, and those medical summaries are helpful. I think Kristen Caldero's point of it is not just the one doctor who might be finding that information helpful, but case managers who are looking at what programs in the community might best serve their needs, the actual options that they might be looking at in the community. Some of my communities have many options for day programs and work sites, and some have very few, and that can be a little bit of a concern for families of what's even out there for me to choose from. We're usually connecting them to county case managers to help from that pediatric side of county case management to the adult side, which might be IRIS or family care at this point in the state of Wisconsin. We're looking at guardianship questions. Many of our individuals might need a full guardian, might need natural supports in place with people that are in their lives, and may not need guardianship questions at all, but looking at that part of things. Trying to help them dream big and think about, I think as Betsy said, no question or no thought is not worth entertaining, because I've been mightily impressed with some of my families and the individuals I work with when they really are dreaming about what they'd like to do for their career or for their vocational interests or their time outside of when school is done. How when they do think about it and pull people together, how they can make that happen. And maybe that wasn't obvious right from the beginning, but it's pretty impressive when they do pull those things together and are living the life that they want to live. So it's a lot more of resource gathering, I think, at that point for me, but trying to be a catalyst for some of that.
The schools are a big part of that too, with their vocational education teachers. That's really what they're for in that high school level.
Right.
Yeah, how many have heard of the post-secondary transition plan? It's called a PTP. So this is now a requirement in the state of Wisconsin that every child at the age of 14, every child, has a transition action plan. Now, some of those plans are very broad because the child is typically developing and there's not a lot that needs to be done. For those in the school system that have an IEP, a Section 504, or something similar, when they're being seen outside of a clinic environment where unfortunately clinicians are only maybe getting, if at best, 45 minutes to an hour with a family, and then otherwise the rest of the time they're home. The education system is a huge part of making sure that that child is sometimes receiving the resources and supports that they need throughout the day. So when they make those referrals to programs like the Health Transition Team, or what I would highlight is our regional centers, of which there's information about them. There are 5 throughout the state of Wisconsin, and depending on where you live, they're going to have resources that are specific to your part of the state. However, they'll have access to things like IEP resources, information that you can take to teachers to talk about. A lot of the special education educators have gone through programs to be prepared to work with IEPs with the PTP process in mind. A lot of our tools we've aligned with the PTP so that educators or those who are involved in an IEP meeting can take this questionnaire or take these tools and say, this is what my child wants to be doing. We've met with our clinician. We've talked about a shared plan of care. This is what my child's goals are. This is how we plan to achieve them. From a health perspective, what that would mean from an education perspective, vocational training that they would receive as they continue on with their education, maybe past the age of 18 in the high school system. But the idea is to then really find out what that child likes, what that child enjoys doing, because that's going to encourage them to have a lot. I know I enjoy my job if it's something I like doing versus doing something I've been told to do because it's something that they say I can do. So we've noticed a lot of that sort of thing happening with the transition process. I focus specifically on the healthcare aspects of things, so we work with the providers to make sure that those types of questions are being asked and part of the IEP process. But there are a lot of really great transition groups out there that are helping with things like employment. And again, those resources are all available through your regional centers.
I think too, I'll add, kind of piggybacking on what the physical therapist said at the back, and Kayla and Betsy, is I encourage, as children reach that place where they're nearing the end of their high school career, whether that's going to be graduating at 18 or moving through some of the transition years, 19, 20, 21, is to begin thinking about how some of the things that they're doing in the school environment translate into the community. Because we have had families who have a lot going on with the school, and the school has been wonderful, but they leave school and then they don't have anything. So if they're using the school fitness center and they're doing all that great work there, taking the time to translate, get it, like, how many of us love walking into a community gym, right? I mean, there's commercial after commercial about just people having issues about which gym I want to belong to. And I can imagine our families and our young adults having that in spades, right? But taking the time to say, how am I going to carry over those fitness things in a place in the community so that when school is over, I all of a sudden don't have a fitness plan in place. Or getting comfortable swimming at the Y instead of the school pool or in addition to the school pool. Or getting comfortable being out at community events when I have my social group through school. But what a shame when that all just is a hard stop because the school environment is done. And as a parent, my kids are grown and gone now, but my husband and I are like, we have no friends. Because all our friends were the parents of our kids in school, and now our kids are grown and gone, and we're like, where do you get friends? Like, what do you do? And so I really think about that as so much of what our kids do is school-based because that's what they're supposed to be doing. But how do we make sure that that doesn't just become a hard stop, no friends, when they move beyond that environment? And I really think we all, as therapists, are paid based on where we work, which is somewhat unfortunate because we all have that same goal in mind. Schools are there to prepare children for life beyond school, clearly. And taking those roles seriously to say, hey, it's not just what we're doing here, it's what we're doing for the longer term. And in the clinic, we see them in the clinic, but being mindful of what are they doing in their communities and with their families and with peers, and how do you build those things so that when school is over, everything isn't over.
Right.
Yeah.
So I really appreciate the way you guys have emphasized the resources that are out there. I'm wondering what accommodations or considerations are made for families or just individuals whose cultural or linguistic background hinders their ability to access this information.
That is an excellent question.
Really good question.
Some of us who've been around a little while remember times where we were we were copying things from catalogs and giving people this, and so much of it now is here's a link for that, here's a link for that, and I always try and be mindful. I try to be mindful that we have some families who everything is accessed through links, and they love that platform, but that not everybody either can or will or wants to. And I think we need to preserve abilities to take the time, is if we're saying we have this information and asking, is that something you feel you can access, or is there a better way I can get that for you? And even if we can't do it all right there in clinic, is following up to say, I'll send you those, I'll send you that printed information, mail it, connect you with people who you can talk to, just speak to directly. But that's an excellent point. I think as the world is moving toward Googling everything, which is great, it has its absolute functions, that we don't forget that that isn't necessarily the best way families can access it or even have time to access it. The other one is making sure our clients have access to technology, even when accessing technology means alternative access. My chart and being able to connect with their doctors and find information about their healthcare needs and resources they themselves want to take advantage of, and not having the access to that be the barrier. And continuing, there's ever-changing technology that we try to stay on top of, but that's like that whole next level too of making sure people are accessing the information world as it is.
I think making sure that we have interpreters present that can help to bridge that gap when we're in clinic. And one thing that I think is missing to some degree is the ability to translate our written information so that it goes into the language of the learner. That's something we still have to work on, I think, as an institution.
There's been some cool research too on involving like community partners, cultural liaisons, so I think that would be a really exciting sort of direction for our work to take too. And just like encouraging families to bring along an advocate if that's something that they're interested in too, or somebody who's important in their community, important in their circle to help navigate some of those different things. I think that's such an awesome question.
Sorry to cut the clinician panel.
Just pull.
You have one more point.
Yep, go ahead.
I was just gonna say, I have two things. One, I want to put in a plug for Family Voices. So we're all parents of kids with disabilities, and we have a great training, very popular training called What's After High School. So those are face-to-face trainings. We do about 10 of them a year around the state, and those are from a family's perspective to families who are going through this and what to expect, what things to know about.
Community voices.
Exactly.
Family, yeah, just for our home people, Family Voices.
Family Voices.
And it's of Wisconsin.
Oh, Family Voices of Wisconsin.
But then I was gonna say personally, at 17-year-old, and even though I know all these transition resources are out there, truthfully, I've gotten nothing from the schools. So I think that you all should know that it's also, families have to advocate for this. I keep saying, I know, tell me, help me, guide me to start dreaming and envisioning what my child could do. So I think that's also really important from a provider's perspective to say, you can be the voice for your child. I have a nonverbal child, so he can't ask, but I think that's really important as well.
So I think Lynn's point was just as parents feeling empowered to be that advocate. And I think Betsy's, I have kids at the preschool end here in the early childhood program, and building that sense of you are their common thread through all the years. Teachers may change, staff may change, and it does, and programs may change, but you are their thread throughout all of that, and finding ways to empower parents to feel like they can be that voice, be that advocate, be that person who's in partnership with their children as they become young adults and then adults in the community, to ask and lead.
And I would just, as the end note, ask the kids what they want. Ask the teens what they want. I guarantee you they have an opinion, whether they are nonverbal, whether they are need some sort of assisted technology to communicate, they have opinions. And as they're starting to take charge of their own health care or in assistance with you, they need to be a part of that decision-making process.
Thank you.
Thank you.
If Justine, if you don't mind moving this way, and then, because then you guys can sit next to each other. Yeah, the microphone is pulled up, because then they can hear the recording. She's gonna try that.
Abby, if you want to introduce them while we're getting situated.
Okay, hi everybody. I'm just going to do some brief introductions while we get everybody kind of positioned in ways that are helpful and work well for the panel. We're so glad that you guys are here. Like Teresa said at the beginning, I often think that everybody's talks and all of the information is so wonderful at these days with the experts, but one of my favorite parts is this end where we finish with individuals who experience cerebral palsy every day of their lives, and the people around them who support them and help them be really meaningful participants in their community, in their life, in their decision making. So today we have a really great group for you guys to meet. I'm going to start right here on the side closest to me. We have Justine Cooper, and she will be talking with you guys using a combination of sign language and her communication system. We also have Laura and Julian, and they're going to speak with you guys about kind of what it's like to be an individual with CP and also a mother of someone who has CP. And then on the other end we have Anastasia, and she goes by Stasha Wilson, and she uses an eye gaze communication system. So you guys, I think Stasha would be more than happy if people want to see how that works, and Justine, you as well, if people want to come up and take a look at the end to see closer up what that looks like, I'm sure they would be happy to do that as well. Cool. So we are going to start today by each panelist giving you a little bit of information about themselves, and then we have a couple of questions that we know we want to address, so we'll start there, but then we're going to open it up, so if anybody has questions that you'd like to ask to this group, just be ready to raise your hand and let us know, okay? So Stasha, do you want to go first and tell a little bit about you?
Hello, I'm Anastasia Wilson, and I am honored to speak to you today. I would like to begin by quoting Einstein. He said, "Everybody is a genius. But if you judge a fish by its ability to climb a tree, it will live its whole life believing that it is stupid." I can relate very strongly to this quote. I view myself as an artist first, and I view my disabilities as just side notes. They are issues that I need to handle so I can follow my passion for art and hopefully become a well-known artist. To help you to have a deeper appreciation for my art, let me tell you about my disabilities. When I was born, I had my umbilical cord wrapped around my neck and my chest, cutting off the oxygen to my brain. The doctors were afraid that they were going to lose me. Luckily, I was a fighter even way back then. The lack of oxygen caused my brain injury, resulting in my cerebral palsy. I have the latest assistive technology to help me lead an active life. I have the latest assistive technology to help me lead an active life. My mom says I have the coolest toys. This computer that you see me talking through is my communication device. It tracks my eyes to select the buttons. It even has the internet. Is that cool, or what? Oh, I drive my wheelchair in a unique way. My headrest is like my joystick. I just press on the middle pad and it will go forward or backward, depending on which mode it is on. When I want to turn to the right, I simply push the right pad and the left pad turns me to the left. So that is how I get around. My father makes my head sticks so I can create 2D art. There were many modifications to the head sticks over the years to assist me to pursue my dreams.
Great. So, and Stasha is an artist. I'm sure she'd be happy to also talk with you guys later about the way she paints and information about her website and things like that. So let's have Julian and Laura go next, maybe? Is that all right?
Yes, it's fine. Good.
And you can pull the microphone off the stand if it's helpful to have it closer. Yeah, absolutely. Thank you.
Hey, good morning. My name is Julian. I'm 20 years old. I live in Evansville. My mom and dad.
I think it's easier this way. Good morning. My name is Laura Gorses, and this is our son, Julian Gorses, and he is 20 years old. We live in Evansville, Wisconsin. Julian has cerebral palsy, and we just find out that he has seizures, that he just developed seizures now. So we're kind of learning the whole new process of seizures. We didn't know anything about it. Julian graduated from high school last year, so he is done with that. 2 years ago, when he was 18 years old, he graduated, and we kept him in school for 1 more year. So he just finished that new transition with it. We felt that the school couldn't do anything more academically for Julian, so it was really no need for us to keep sending him over there. So I've been researching a lot for other options as a parent and what Julian can do after school. And it was really, really, really hard to find the right place to fit Julian's needs and to be an advocate myself and make sure that he was safe, but he was also happy and content. So it took us a whole year to find the right place, and I'm happy to say that he is in a day program now, 3 days a week, and going over there, and he really, really enjoys it very, very much. So that is pretty much what we are dealing with right now, but and Julian, we're dealing with him every day, so you're never bored.
Get away from me.
Yeah, we're never bored with him, so that's good.
I love it. I'm going to move the microphone a little closer to your device, just this one, so that your messages are nice and clear. Okay, go ahead. Yeah, let everybody know whatever you'd like.
Hello, my name is Justine Cooper. I currently live in Delavan. It's important to me to be a good person. I have difficulty talking and I use sign language and this computer to speak. I have a husband and a son who is going to be 14 years old. My house can be a zoo sometimes. I have 4 cats, a lizard, and fish. As a mother with cerebral palsy, sometimes it can be challenging to raise a child. But luckily I have a husband who helps me make it through.
Okay. Great. Wonderful. Thank you, Justine. Thank you, everybody, for giving some background about who you are and kind of giving everybody a little insight into your lives. And now we'll work on some question and answer where you can learn even more. The first thing that we talked about today as maybe a starting point with a question that gets brought up many years here is, what has been your guys' experience with inclusion? And that can mean inclusion. We think about that a lot from the school standpoint, inclusion in the classroom, inclusion in participation, but inclusion is really something that spans our life. So how are you included in your community? How are you included in any volunteer or work things that you enjoy? How are you included in your family and all of those things? So let's see, is there anybody, Justine, would you want to go first on this question? Or do you want a minute to think? Okay.
It doesn't matter to us.
Okay, great.
So
Well,
really,
thank you
you wanna
guys.
tell them what you do and why you volunteer and work, stuff like that.
I work in the library. I used to work in the library and
The manor
and
and assistant living.
you speak.
So with Julian, you know, him being 20 years old and stuff like that, we started really early, knowing that he was different and it was going to be a challenge. So my husband and I, we kind of learned as we went through. When we first found out that Julian will have cerebral palsy, we didn't know anything about it. And to be honest with you, we are Latino ourselves. We came from a different country, so we didn't really know what was happening and how was going to be, this journey was going to be. But to be honest with you, it has been amazing for us in our perspective, just because, you know, my husband and I, we are very involved in Julian's education, medical decisions. Everything that we do is for Julian's welfare, and that makes such a big difference. And I did overhear somebody saying, you know, how do you need to be the first advocate for your children, and it's true. Even if you don't have cerebral palsy or even if you don't have seizures, you need to really go out and advocate for your children. So that's what my husband and I, we've been doing. We had a great team of teachers from the beginning, but I was really involved on letting them know what Julian's needs were and also what Julian's challenges, but really what Julian's strengths were. So we need to focus on the strength and not on the other side of it. So it has been a really good journey for us because, you know, I've been really, really involved with Julian's education and Julian's medical part. So he has never missed an appointment, I don't think. And so we always bring him in, and we always want to make sure that he knows what's going on. But if he, you know, if he has questions, I would like for him to ask the doctor as we learn ourselves everything. With the school, it was a really good experience because, like I say, we've been very involved, but also they really listened to what our needs were because I really advocated for what we needed to focus on. I knew what Julian's limitations were, so we really wanted Julian to be very social in the community, and that was very important for us, for him to get involved in our community. So he did a lot of volunteer work throughout the years with me. And then we had Julian with the DBI program working, and he tried 90 days, and then we went to another place, and you know, now he's thinking about some college, some school. So, and you know, so we're always trying to get him involved as much as possible. With the CISA program, like I say, it has been a really good experience, but it took a long time for me to find the right place for Julian to be at. I just didn't want I didn't need a childcare for my son. I didn't want somebody just to watch Julian. I wanted him to be involved and really focus on what we've been working on for the last 20 years. Anything else, Julian? No?
Thank you, guys. That's great. Justine, would you like to go next?
Yes.
Okay, great.
After high school, sometimes I tried things, but those things didn't work out because there was so much red tape to get through just to get a job. I did go to college for 2 years. My experience overall was good. The college provided me with a good tutor, note takers, and extra test time. I would encourage you to advocate for the supports you need to be successful.
Great. Did you want to talk a little bit about, I know we had talked a little bit about what it's like for you to go out into the community as well. And I think we talked about transportation and barriers, so that would be a great thing to share too. Thank you.
I attend community events such as going to Deaf Club, shopping, going to the park, and taking hikes. It can be hard to find transportation to get places you want to go. Right now I have my own accessible van, but sometimes people cannot drive me to appointments, so then I have to use other van services. I use MTM4. appointments, and I can even request a specific driver if I have a preferred driver. Having backup transportation is important for me to do the things I want to do.
Great. And then Justine, is there anything else you can think of that you want to add? Okay, great. How are you doing over there, Stash? Are you ready? Okay, go ahead.
Since I talk through a communication device, I talk slower, but my good friends are very patient with me. I feel very lucky that I have good people in my life.
That's great. That's great. And I think to give you some context, I work in a clinic where we work with individuals who use these communication systems to communicate. And I think one of the most important things that everybody can learn from working with or talking with individuals who use these systems is that patience that Stasha is talking about, and knowing that they have really meaningful things to communicate, and even though it might take a little bit longer, it's definitely worth it. Great. So this is perfect. This is a good segue into some questions from you guys, and it looks like Katie has one for us already.
So I was wondering, I'm looking at the technology, and I'm wondering how these advances in technology have changed your ability to participate, in the community and to sort of follow your dreams.
Yeah. So I'm going to repeat the questions just in case on the live feed it's harder to hear. So Katie's asking about your guys' experience with technology and how changes and advancements in technology have led to differences in how you're able to engage and participate in your community. Do you guys want to go first?
Yeah. For me, the first time that Julian was able to, so he uses an iPad, and it was really hard for a long time for him to do the speech. So throughout the years, we've been doing so many therapies and stuff like that. When Siri understood what Julian said, Siri, I'm sorry, it's my accent. So when Siri said, when Julian was able to say something and she understood, that was the most amazing feeling. Not anymore. Not anymore because now I think Siri is like, okay, give me a break. But I think it has been amazing that, he now presses a button and he's able to get everything in front of him, and I'm just so fascinated by it. So speech therapist is really, really good. I don't know anything about that. That's true. I don't know anything about technology. Not at all.
Julian, you're giving away all your mom's secrets. I better watch it. She's gonna.
I need to.
You need to? Okay, great. Stasha, are you still working over there? Yeah? Okay, great.
Actually, yeah.
Oh,
Yep.
perfect. Justine has something to add.
Technology has definitely helped me more in the world. I'm definitely a part of things. It's definitely better.
Great. And Justine, if you're willing to give us a little information too about the way that you use two very different modes of communication. So you use sign language, and I think to give some context, deaf culture is a really important culture in our community, and there's a lot of pride and really wonderful things about using sign language. So sometimes there is some kind of, I think people sometimes can see it as like competing priorities with using sign language versus using communication systems. But Justine, I think you're an awesome example of somebody who has found a way to use both of those and figure out how different strategies work at different times. Can you tell us a little bit about your experience as a sign language user and a communication device user? And to give you guys context, Justine's device is newer. She got this one like 2 months ago, was it?
Yes.
Yeah, like 2 months ago. So she's a wonderful user for only having it for that long, but maybe we'll talk a little bit about your experience so far.
The device is really great because it helps me if I wanted to speak on the phone.
because then I can just put the phone up to it and I can speak through my computer to the phone, which is fun.
Yeah. Is that it?
Yeah. Interpreter. So what that does, to clarify even more, is that I can set up the phrases on my computer, and then through an interpreter, they can hear what I'm, they can people can hear what I'm saying, but then so the interpreter will just sign responses back to me on a video screen. So it's almost like on video, where I can see the interpreter and I can see the signed responses, but for myself, instead of signing, if I pre-program information, I can set it up on my device to talk to the person directly.
That's pretty cool.
It is.
That is cool.
And I think, there was a question asked earlier, Justine, about whether it's ever too early or too late to try assistive technology, and I think Justine is a remarkable example of someone who has used varying forms of technology, but has had the courage to try a new technology at a different point in her life and finding out what it can do for her.
Yeah. So just to recap, Mary was talking about the question earlier during the clinician panel about is it ever too early or too late to start with technology and things like this? And Justine, I think you've shown us that you are, brave and you're just crossing into.
I don't think you should have a barrier on age. You should be able to do anything at any age.
That's great. I love it. All right, Stasha, do you have something ready? Do you need a little more time? Okay, great. Is it okay if we take another question and then we'll have you give your response too about technology? Okay, thank you. All right. Anybody have any follow-up questions on that or anything else?
I'm just going to make a comment because
Okay.
it's so amazing.
Yeah.
I see people using, lots of different modes of communication.
Mhm.
And I think this really highlights how complicated communication is. That it's
Yes.
not just about speech. It's not just about using a communication device.
Right.
This idea that, people use sign and a voice output device and,
Yes.
and some natural speech
Yep.
and an interpreter, and
Yeah.
and
And Siri.
iPad, and he's using his speech and Siri,
Yeah.
and
Absolutely.
Sasha is using a more traditional, super fancy
Yes.
AAC system. I love this continuum
Right.
of the ways that people communicate.
Absolutely. I agree. The overview is this is so powerful to see so many modalities of communication that are coming together in really cool ways. Is your question about communication? Okay. Would it be okay if Stasha gives her response and then we'll do your question? Okay, thank you. Go ahead, Stasha.
I used to have to dress a head stick to press the buttons on the communication device. In high school, I used to feel embarrassed because I talk so differently. I used to be so shy that I would have never imagined that I would be doing this. This device follows my eyes. It is easier.
So, to give some background about what Stasha's talking about, a head stick is actually physically a stick that was positioned on her head using like a hat or a headband, and then she would have to move her head in order to select messages either on a low or a high-tech system. So I think we all could imagine how strenuous that would likely be to do. So this technology has come a long way, hasn't it? Okay, great. Let's have your question.
My question is, expecting more. I have a 6-year-old who has a level 3 for mobility.
Okay.
And I'm guilty of maybe doing too much for him. He picks up his own toys, but that's about to get him involved, and like, I know, Laura, you had said, that you and Julian had done volunteer activities, and he's doing jobs, and also, well, both of you ladies too, what kind of things can I push him to do that he might be capable of?
Yeah. So I'm going to just repeat the question really quickly. So I think it's a great question about what can parents do to encourage their children and help them be more independent and give them opportunities to do some things on their own. Does that pretty well capture it? Okay, Laura, go ahead.
Well, for us, I think it's very important for me, myself, it's very important to involve Julian. So really asking him, knowing the strength and what he's able and capable of doing. So I don't give him a lot of choices, but, I do give him, okay, either red or blue shirt, because otherwise I would spend the whole entire day trying to figure out an outfit. But, for us, it was really more about taking the lead from Julian at some point, and then knowing the expectations, and then realizing for us, and I'm speaking for myself and my husband here, for us just having those really high expectations that he was able and capable of doing stuff. So we never really put a lot of limitations, even though I knew that Julian has cerebral palsy, and everybody who has been working with us throughout the years knows that my standards are really high for Julian, and I think that makes such a big difference. I know that he was capable of picking up his toys, but also able to set up the table. So that was his job. And okay, after you're done, so we always try to work it out with him. Okay, so you either, you're part of this family, so how are you going to get involved with it? And then going to the community and volunteering, I know that he didn't want to go to Archangels, but he didn't. But I think it's very important that Julian knows. Excuse me. I think it's very important for him to know that it's okay for him to be in a wheelchair and being able to help others. And so the same way that that he has help from other people at home to find caregivers. And this is kind of off topic, but trying to find somebody to work with your child at home is very, very difficult. And like I say, my expectations are really high because Julian is my son, and I never treated him differently because he has cerebral palsy. But it was really hard for me to find somebody, so I used an agency. We had 28 people in 1 year, so just to kind of have an idea, because you're not taking care of a bag of potato here. I don't need a babysitter. I need somebody who is going to interact with Julian, who is going to do his speech, and he's going to do the stretching and take him swimming and stuff like that. So it's really, really hard, especially on your home, and just making sure that your child knows, that you're doing this for his own well-being, but also that he is able to, get that connection with him and having that relationship, so if something happened, he will be able to communicate with me and say, well, this happened, so what are you going to do about it? And he tells me that all the time. Somebody's late, and he said, what are you going to do about it? I'm like, okay, well, we need to find out first what happened. We just can't fire people. But, I know. So, and like I say, because we have those really high expectations, I think Julian has become this demanding little man. And yeah, you get it from me. But and I think having that sense of humor at home, having that relationship and stuff like that, it makes such a big difference, because now I feel like, we have a better relationship because we did all those things together, and we have those really high expectations for him. I always tell everybody this story, we have dinner, I make dinner, we had a glass of wine, and I say, Juli, dinner is ready. In 5 minutes. And he slammed the door in my face, and he said, I'm not hungry, I'm not eating. I didn't argue with Julian. I was like, okay, that's fine. I went, I had dinner, we had our glasses of wine with my husband, I picked up the dishes, did the dishes. Like an hour later, he came, I'm hungry, I want my food. And I told him, I said, well, this is not a restaurant. So he went to bed without any food. And the next day, he was there when I say dinner is ready. because, you can't really negotiate. You can't be having all this, fit everything towards his needs, because reality is when he goes out, this, not everybody's going to fit his needs. So he needs to learn that there are consequences for your actions. So, and when you have those expectations and when you have that relationship, I think that you're really giving him the strength for him to say to me, well, this incident happened at school and somebody made fun of me. And so I said, well, do you want to deal with it or you want me to deal with it? And so he said, no, give me a couple of days, I will deal with it. And so I will text the teacher or I email somebody at school and I said, well, this is what happened. I want Julian to figure it out. And I am proud to say that out of those 10 times, 8 times, he fixed the problem himself because he knew what to do. He went to the right person, he talked to Mrs. Mills or, whoever, and he said, but, if I am babying him all the time and I'm schooling him, I'm not really giving him all the tools that he needs for something really big happening in the future, and God forbid something happens to me or my husband, he needs to know that this is life. This is, something that is going to happen in the real world. So as much as you try to put them in a bubble wrap, you kind of have to be realistic and really be, okay, these are consequences for it. So.
Yeah, that's great. Anything else, Julian?
No.
No? Okay. Julian, if you ever change your mind, just give us a holler and we'll get that microphone up there for you if you have anything you want to add, even if other people are talking. Let us know, okay? Sasha, it sounded like you were typing away over there. Do you want to let us know?
Well, my parents always pushed me to do everything that I could. Like my dad takes on motorcycle rides, although my stepmother thought we were mental at first. My mother really pushed me on going to college.
That's awesome. That's great. I love it. Justine, do you have anything you would want to add? And I think you have an interesting perspective too, not only growing up as somebody who has CP, but now also raising another child yourself. So if you have any on both sides, from the child side or from the parenting side.
Mine's same thing. Oh. My mom taught me the same thing. Okay. My mother also did the same thing where she advocated for me, but she made me do the things on my own.
That's great. I think we might have even put in a message about this, did we?
I think so.
Let's see if we have your mic up here.
Yep, that's the one. There we go. Perfect. Thanks.
Yeah, absolutely. I don't have the best memory, so it's lucky
I
that.
grew up at a time when it was hard because my body was continuously stiffening and movement got harder and harder, but I didn't give up, and that's why I am where I am now. My mom pushed me to do things myself.
Absolutely. Great. Okay, cool. So we're getting close to the end of the discussion. So I'd like to kind of wrap up here and thank our panelists and have you guys join me in thanking them. And then I would welcome, if any of you guys need to buzz out, we of course respect your time, but if there are any questions or follow-up things, if you guys are willing to stick around for a little bit, we could also invite people to come up and just kind of wrap up that way as well. Teresa.